and honored to have as our speaker for Women's History Month, Dr. Kathie and Joseph. I'm going to let Dr. Gameda do the formal introduction, but thank you for speaking today for Hackensack Meridian, and all of us are really looking forward to your talk. So thanks so much.
Thank you, Dr. Boskamp. And it's a great pleasure to introduce a good colleague with whom I had the privilege of working a few years ago at NYU School of Medicine. Dr. Kathie Ann Joseph is currently a professor of surgery and associate chief surgical officer at Rutgers Cancer Institute, chief of breast surgery, co-director of the breast oncology program, and director of breast services at the RWJ Barnabas Health's Southern region. Dr. Joseph holds leadership roles across many professional organizations. She serves on editorial boards of the Annals of Surgical Oncology and the American Journal of Surgery, and is an examination consultant for the American Board of Surgery's Complex General Surgical Oncology Continuous Assessment. She chairs the Research and Education Committee for the Society of Black Academic Surgeons and is vice chair of the American College of Surgeons Committee to Advance Surgical Excellence and Inclusion. In 2024, she was appointed to the board of directors of the Accreditation Review Council in Surgical Technology and Surgical Assisting by the American College of Surgeons. She's a member of the American Surgical Association, the Society of University Surgeons, the American College of Surgeons, the Society of Surgical Oncology, and other national organizations. Very importantly, Dr. Joseph has been dedicated in breast cancer screening in underserved populations, and she previously served as the co-director of the Beatrice Welter's Breast Health Outreach and Navigation Program for 10 years. She was also the first medical director of the Kimmel Pavilion Unit 3 post-procedure unit, one of the busiest and most important patient care areas at NYU Langone. From 2010 to 2021, Dr. Joseph was the chief of breast services at Bellevue Hospital, and in 2015, she was named NYC Health and Hospital Bellevue Physician of the Year. She graduated from Harvard College and earned her medical degree and master's in public health from Columbia University Vagelos College of Physicians and Surgeons and Columbia University Mailman School of Public Health, respectively. She completed her general surgery residency at the NYU Langone Medical Center and her breast surgical oncology fellowship at Columbia University Medical Center. An advocate for inclusion and mentorship, Dr. Joseph served as president of Columbia Vagelos College of Physicians and Surgeons Alumni Association and founded the Columbia Vagelos College of Physicians and Surgeons Women in Medicine Collaborative to support women medical students. In recognition of her service, she received the Columbia Vagelos College of Physicians and Surgeons Gold Medal and Columbia Alumni Medal from President Lee Bollinger in 2022. Thank you so much for joining us today, Dr. Joseph, and looking forward to your wonderful talk.
Thank you, McBeeb, for that kind introduction, and thank you for having me. I will share my slides. Okay. Okay, can you see that? I'll just put it on full screen. Okay, great. So I will be speaking today about my work on breast screening and navigation. I don't have any relevant disclosures. And this slide sort of gives you a sense of the work that I've done and my expertise. As McBee has mentioned, my focus is really on breast cancer, but also high-risk populations. And my focus is on patient navigation and high risk in underserved communities. I'm a co-investigator on R01, and also my funding had come from the B. Welter's Breast Navigation Program and some other philanthropy. So the question is, we do talk about disparities in all aspects of medicine, but the problem is why do they persist? Like we're always talking about it, but how can we address it? So as far as breast cancer is concerned, we have come a long way over the past several decades in in the management of breast cancer. We now have new approaches, neoadjuvant approaches. We can now treat breast cancer with chemotherapy beforehand, before doing surgery to shrink the tumor. Occasionally, we can go from a patient having locally advanced to now we can have a complete pathological response. We now talk about personalized medicine, de-escalation of treatment. We've gone from doing axillary dissections to now sentinel nodes to now we're talking about not even treating the lymph nodes surgically. So there's so many different options in our armamentarium, and we're also now focusing on survivorship and precision medicine and prevention as well. But the problem is that not all populations are benefiting from all the work, the great work that has been done over the years. Breast cancer care requires a nuanced, multidisciplinary approach from of diagnosis, and um, not all patients have the benefit of going to um, cancer centers or NCI designated cancer centers. We've also gone from treating breast cancer as or looking at it from an anatomical standpoint to looking at it from the approach of looking at the biomarkers, the genomics, and that has started a whole boon of new medical treatment options for patients. And that requires really significant scientific rigor. And again, we have to look at the patient holistically. We have to think about prevention. We have to look at look at the early onset of breast cancer, but we also have to look at the patient beyond the treatment and onto survivorship. And that has triggered a whole opportunity of study with longitudinal follow-up. So I show this slide. It's a little old, but it's very relevant. This slide actually triggered a lot of discussion when it was first published by Mark Hulbert and his colleagues about the widening disparities in breast cancer mortality. And as you can see, the black women are in the black line and white women are in pink. So both lines show the mortality rate over a 10-year period, but the problem is that not only are the mortality rates for Black women still higher compared to white women, but the gap is widening. And so this is the stubborn problem that we're still facing for those of us that treat breast cancer, is that the gap is still widening. And how do we address that? When we look at breast cancer screening in New York State, we know that women who are uninsured and women who do not have a regular primary care provider are less likely to undergo breast cancer screening. And also this slide, which looks at the percentage of women that go unscreened for breast cancer. When you look at the counties in New York State, the darker the pink, those are the counties that are more likely to have women that are unscreened. And then when you look at the number of women who are eligible to be screened, who are uninsured, those are the dots. So the bigger the dots are the women that are uninsured. And you look at New York City all the way at the bottom, showing here, if you can see my cursor, we see so many women here in New York City that are uninsured, that should be eligible for screening. And so what are the causes for this? And there are so many structural and social drivers. There's structural racism, social determinants of health, screening and diagnostic delays, as well as treatment inequities. And I would submit to you that if disparities are shaped by systems, they also have to be addressed by systems. And so one of the interventions that we leveraged was patient navigation as a systems level solution. And so before I talk about the work that I did at Bellevue, I want to talk about another hospital, and this is Harlem Hospital. Um, and Harlem Hospital is where really is the birthplace for patient navigation. And this is Dr. Freeman, who's considered the father of patient navigation. He's a surgeon. He was a president of the American Cancer Society, president of other societies as well. But while he was the president of the American Cancer Society, he did a tour around the country where he spoke to cancer patients as well as their caretakers. He wanted to know what were their experiences like, particularly disadvantaged patients, um, and what were their barriers. And he issued this report in 1989. And this was personal to him working at Harlem Hospital, where he was seeing patients coming in with very advanced cancers. And so this report, called the Report to the Nation on Cancer and the Socioeconomically Disadvantaged, really is talking about what we now call, health-related social needs or social determinants of health. He addresses the substantial barriers to obtaining care that socioeconomically disadvantaged patients face, the sacrifices, the extreme personal sacrifices to obtain and pay for care, the fatalism, the lack of adequate cancer education programs that are often culturally insensitive, and also the greater pain and suffering from cancer that these patients face. And so and I also had the privilege of spending an elective with him when I was a medical student. So I'm really dating myself as a medical student at Columbia. Um, and seeing so many patients, they're coming in for screening or they're coming in with a complaint and going for mammography. And somewhere along the line, they're getting lost in the system and not coming back, even though they have an abnormal finding on their mammogram. um, he developed this patient navigation model. And this slide is from his original paper that he published in Cancer. So this was his original model for navigation. It's obviously evolved since then, but he proposed that this navigator would do outreach to women that had an abnormal finding on mammography and would track down that woman, inform them of their abnormal results by phone, and then make sure they came back for whatever additional imaging and biopsies and make sure they went on for treatment. And once the woman was done with their treatment, that was the conclusion of navigation. Now, obviously, navigation has evolved since then, and it's also been translated into other disease sites, but this is the original model that Dr. Harold Freeman described. So how does this look implemented at scale? Well, in 2016, my colleague, Dr. Ravenel, and I had the opportunity to create our own navigation program after a patient, a Black woman, was treated at NYU and felt that while she was fortunate to get great care, she understood that not everyone had that opportunity. And so we were tasked with providing a proposal, and we put our heads together and we said we recognize that there are a lot of programs that treat women once they're diagnosed, but we knew based on that earlier slides I showed you, we knew that there were a lot of women in the New York City area, particularly in Brooklyn and Lower Manhattan, that don't have access to screening, and we knew we were missing them, and they weren't coming in. And so we were able to get funding from this very generous patient, Mrs. Beatrice Welters, to start the breast health outreach and navigation program that we envisioned to be a model for patient navigation and using non-clinical navigators to go out in the community, but also to help women who are newly diagnosed as well. In order to achieve this mission, we were going to do, it was a tripartite mission of outreach, and leveraging and building community relationships with community-based organizations, and placing culturally congruent navigators at churches and salons and other community sites. And then also education and developing and distributing educational materials that the women can relate to. And obviously, we would have navigation. And we leveraged insights from Dr. Ravenel's barbershop program, where he was already using navigation in that sense for colon cancer um, uh, education in the barbershops. And so the goal was not just to navigate to, but through screening, treatment, and the entire continuum, including clinical trials. And underlying that was research. So we actually first did our own research, and we did a landscape analysis, and we actually looked at other navigation programs across the country. We visited some of them, and we saw what they did and what they focused on, whether it was focusing within the hospital system or within the community, and what kind of what did they offer the patients, what kind of services were offered. And we decided that we wanted to do the full gamut because we felt it was really important to make sure we were doing outreach to patients that normally would not be part of the healthcare system. And so we launched the program in October of 2016 in Brooklyn, at the Brooklyn Botanical Gardens. And this is Mrs. Walters here in the gray suit. And it was 2016, so we, and using her connections, she had the mayor's wife at the time, Shalane McCray, I think is the last name again. And we had some other people here from NYU, our former dean, Grossman, his wife, our former cancer center director at the time, Ben Neal, and some other local representatives from Congress. This was Hakeem Jeffries, and I'm trying to remember her name, our other congresswoman. And so it was really a wonderful opportunity to, and also very significant that we launched it in Brooklyn, where we felt that was one of our greatest needs. Sorry, this is Yvette Clark, excuse me. And actually her mother, she took her seat, Una Clark. So, and then we leveraged that program to write another grant, which we were awarded from the New York City Department of Health, which allowed us to expand the program. It allowed us to hire additional navigators, expanded our scope, allowed us to do outreach and navigation into beauty salons, barbershops, faith-based organizations. And also, we were able to embed some of our navigators into primary care sites within the NYU Brooklyn system, which has one of the largest federal qualified health systems in the country. And we also got some additional funding from other philanthropy. We developed an oversight committee. We wanted accountability, and these were some of the experts both within the NYU system as well as across the country, and we valued their insight over the years. And we also, these are just some of the community-based organizations and other organizations that we partnered with that provided us with insight, support, and also actually refer patients to us. And so this is pretty much the scope of the program where basically we envision this as providing our patients, starting with the community and developing educational materials and outreach. And we would then, patients would agree to be navigated to screening, and they would be navigated to any of our sites. And actually, we expanded that to anywhere in the city. We wanted to make sure that patients did not feel restricted by geography. And so very quickly, once we started the program, we actually would send patients to wherever they wanted to go. And then if the mammogram was normal, we just followed up annually. And then if there was abnormal, that navigator then made sure the patient followed up with their diagnostic services. If they were diagnosed with cancer, again, the navigator would follow through all the way through to treatment, whether that was including surgery, chemotherapy, radiation, and along with that, making sure that they were referred to any supportive services And also, it was important that they were aware, and we were already doing this, but making sure that, and our navigators were also familiar with the clinical trials, and then onto survivorship. We developed tailored materials. In the first year, we developed literature in English and Haitian Creole and Spanish. And then in the second year, we added on Chinese and materials for the LGBTQ community. And so, and then while our initial focus was in Lower Manhattan and Brooklyn, because that was the NYU catchment area, as the word began to spread about our program, we quickly decided we would go wherever the need was and where we were called to. So we were all over, and we went to senior, as you can see, these were the type of events we were called to, whether it was a healthcare, churches, social service organizations, senior centers, healthcare facilities. And we went to all 5 boroughs, and even you can see there's one little dot there on Staten Island. But why does this matter? Because our navigators, and I'll go into that a little bit more, um, you know, this was an IRB study, and as well as we're providing a service. Our navigators are trained for any patient, whether they're doing screening or we're providing diagnostic treatment for them. They are trained to do barrier assessments, and we did make sure that we are making sure that we are addressing those barriers with these women. And so it is important that we're just not documenting them, we are making sure that we address those barriers. And so we have now close to 10 years worth of barrier assessment data on the women that we are servicing. And that's very important. Where do these people come from? Most of the patients that we helped came from Brooklyn and Manhattan. Half of the women almost from Brooklyn, and 26% from Manhattan. They're primarily Black and African American. 48% are Hispanic. Sorry, Black, African American, or Hispanic. And then as far as the neighborhoods that we are serving, mostly in Brooklyn. 36% are East Flatbush, 20% Flatbush, and 16% Sunset Park, which is where NYU Brooklyn is located. We now have a dedicated navigator in Harlem, and so those numbers will continue to increase. When we look at the impact over the years, this is our year 9 data, which is of 2025. We provided breast health education to close to 29,000 women and enrolled into navigation 8,000 women and navigated close to 4,000 women to a breast health appointment. And then 123 women were diagnosed with breast cancer through our program. And that's not including other women that we enrolled into our program with cancer that were diagnosed through community-based organizations or through our clinics and so forth. And then 54 were enrolled into clinical trials, and we did a total of 538 community outreach events. And to give you an example of how our navigators help our patients, this is a patient story. Sheila, she's one of our first hires, and she's now a senior navigator. And she helped a woman, premenopausal woman who came to Bellevue from Texas. This was during the time when the governor of Texas was sending undocumented immigrants on buses into the middle of Manhattan. Patient came in the middle of winter with her family, a husband, 2 babies, a 2-year-old and a 7-month-old, and they clearly were not dressed for the weather. And she came with no medical records. And while we were trying to work her up and figure out what was going on with her breast cancer, Sheila's doing her whole assessment, but also noticed clearly she was not neither the mother, the patient, or the babies were dressed for the weather. And so she quickly mobilized to get them the appropriate clothes, coats, hats, gloves for the mom and the children. So this is all about what do? They do assessment needs assessments. They do connecting patients to available resources, liaison with the clinical team. They're part of our team. They come to our multidisciplinary conferences, so they know what's going on with our patients. And they make a cultural connection. Many of our navigators are bilingual, if not trilingual. And excuse me, and they also support digital literacy. I know we're all about doing my charts and so forth, but we should not make the assumption that all of our patients can understand how to use my chart to communicate with us or to keep track of their patient appointments. So our navigators are very helpful in just making sure our patients understand all their appointments and what time and dates of their appointments. This is our team. We have Megan, who is our administrative director, Anita McFarland, the senior manager and administrative coordinator. These are our navigators, Sheila, Jackie Berry, who speaks English, French, Haitian Creole, Spanish, Patricia, who's our Harlem navigator, Rochelle, who's our NYU Long Island navigator, who's also fluent in French and Haitian Creole, and Tashana, who is bilingual and speaks Spanish as well. And then our whole genetics team here that falls under the program. But most importantly, research is important. It's important to document the work we do and why it's important. And so working with one of our fantastic students that that worked with us remotely from Chicago, who's now an intern, we did a work looking at the unmet social needs of these patients and looked at the barriers that our patients reported and found that 30% of the patients enrolled in the navigation program reported transportation barriers, which surprised a lot of people who don't live in New York City and assume that that's not an issue, but it really is an issue. And mostly because of the fact that so many of our patients live in Brooklyn and they live in the outer portions of Brooklyn where they have to take a bus and a train, or they may have to take two trains. So getting into Manhattan from Brooklyn is actually is a problem for many of the patients. And that transportation barriers are strongly associated with unstable housing, poor health literacy, and depression. And that the patients that face a greater number of barriers are associated with a longer time to treatment. So that's one study, and she actually presented that at the American College of Surgeons as an oral presentation. And then one of the residents, actually, we just came back from the SSO last week, presented the work on language barriers to health literacy and mental health. And he looked at the barriers that our non-English and English speaking patients report, and found that our non-English speaking patients were more than 4 times more likely to report health literacy barriers and twice as likely to report concurrent mental health challenges. And what's really interesting is that these disparities have widened since the pandemic. So not sure why that is, but that barrier, those disparities have not decreased since the pandemic was declared over. And kind of related to this, because we have been working, our navigation program has been working with the disabilities group. Our medical student wanted to look at our patients with disabilities, and we have a clinic at NYU that provides primary care to women with disabilities, and we looked at screening mammography rates at this clinic for women with disabilities, and we found that in this clinic, even though these women were referred for routine screening, 40% did not receive breast cancer screening, and an additional 15% of those that went, 15% received suboptimal screening, including just receiving an ultrasound instead of a mammogram. So 42% of the patients received screening according to ASBRS guidelines, which is substantially lower than the national rate. So even when you have a dedicated clinic for an underrepresented population, that does not mean that they will get optimal care. So we are partnering with Dr. J.R. Rizzo on an R01 for this grant called ABLE, Addressing Ableism Through Accommodations for Blindness and Low Vision to Achieve Equity in Healthcare, so that we are looking at how to address barriers to care for patients who are blind or have low vision, and how we can leverage the Welters program to address those barriers. And so so we have Anita McFarland, our manager, and Sheila Willis, one of the navigators, and myself are on this grant. So I just want to shift gears a little bit and talk about the fact that health equity is a quality of care issue, which requires leadership. It requires accountability and systems redesign. And so McBee talked a little bit about some of the work I did as in IHE, the Institute for Excellence in Health Equity, and as a medical director. And so the reason why I bring this up is because when we talk about health equity, even on a systems level, one of the things that we talk about is what are meaningful outcomes to patients. And so we would talk about this at NYU, where I just left. And when we talk about, and so it's important to make sure that patients, when we talk about these things, whether it's mortality, length of stay, readmission rates, patients come in the hospital, obviously they don't want to die. And they want to get out the hospital as soon as possible. And when they get out, they don't want to come back. They don't want to bounce back. So we focus on these things, and we focus on how do we make sure that we, amongst our peers, that we are the number one, and how do we remain number one? And so the question was, how do we move the needle? And this is how my work in health equity also meshed with quality. And so, and health equity is one of the domains of quality. And so it means that you don't do this work in isolation. You have to work with hospital leadership, and your peers are also important in this journey. And so in advancing health equity, you have these foundational areas. You have the health system governance. You have to look at data collection and the facilitation of disaggregation, the transparency of data, and the visualization of these disparities, as well as organizing these measures of equity. And so one of the things I did while I was there was looking at some of the categories of demographics and how we collected these demographics in EPIC and MyChart. And I was responsible for disaggregating this data. There was a method to the madness of why we were doing this for health equity. And so we knew we didn't know who we needed to know, how to have a better way of knowing who our patients were. And so we needed to assess for the population and our subpopulation level differences, and also compare processes and outcomes to assess for disparities related to race, ethnicity, language, culture, sexual orientation, gender, or along lines of specific social determinants. And so we decided, and we brought in a whole group to do this. It wasn't just me alone. We had people from Pop Health. We had folks from the different campuses weigh in on this, and our leadership. It was based on the requirements. We knew that race was based on requirements for CMS and New York State Sparks. We had 25 categories with the option to multi-select, and we actually changed the name to race ethnicity with 10 categories. But we also had another category for race, which we call detailed race ethnicity, and we opened it up to 42 categories. That was based on the top 5 ancestry groups for each aggregate race ethnicity in the New York City metropolitan area. You also have to, and I learned a lot by working with our computer folks there about MyChart and the interface and how everything comes together. And so this was our current state, and on the website, on the computer, and also on the phone, on the mobile unit. And you have to make sure everything looks, how everything is going to look and how much you can fit on the screen. And so we changed everything around. We changed the dates. We had to make sure that all the wording was going to fit. And the same thing on the kiosks when you come in and use the kiosk. And so we changed all of that too. And we had to talk to the ambulatory folks as well because when you're going to a doctor's office, efficiency is extremely important as well. And so we changed the language around there as well. We actually, it's important to communicate why you're doing this, not only to the patients, but also to the staff. So patients are going to have questions. They may want to know, why are you doing this? Why are you asking me these questions? Even though we're making a change that from something that we were already asking, given the climate, we wanted to make sure, and we had videos, and they asked Il-sung Cho, who was the chief quality officer, and me to come up with these 60-second videos. And also, we also did as part of the HRO weekly messages that our chief medical officer will often send out. They asked me to send out one instead, 1 week. And then it's important to have data, right? To show, does it make a difference? And we showed that we did improve the capture of real data by doing this, making this change. And we did the same thing for SOGI. But it's also important to have data visualization and transparency. And so we are able to build a clinical health equity dashboard. And by doing that, we're able to then look at those metrics that I talked about earlier, 30-day readmission rate, mortality rates, and so forth. And then we're able to segregate by different races. And then we're able to look at any department across the health system, not just in the Manhattan, but Long Island, Brooklyn, Hospital for Joint Disease, and we're able to filter. And we're also able to filter not only by race, ethnicity, but we can also do it by sexual orientation, legal sex, preferred language, payer mix, and we're also able to look. We can do look across the map of New York City, and we can see where there are hotspots. And then when we click on if I was to look at a zip code, we can pull up the zip code, pull up the patients, and go into the Epic chart to then see is there a problem. And then what we would do with the hospital leadership is then go back to the department chair and say, hey, you have a problem. For instance, why we could go to the chair of cardiothoracic surgery and say, why are your African American patients having a higher readmission rates than the rest of your group? So your group may be doing well with readmission rates, but we do know that there's ways to get more granular, and that's how we move the needle. And so this is the same thing that we did for our navigation program too. We have our own dashboard. We started with our program, and then we built it out for the other disease sites in the cancer program. And so this helps us to be more lean. A lot of our navigators like going to certain places, and they will say, you only recruited 1 or 2 patients. It's not a great use of our time. Maybe go back to this other site instead. And we can also track how well our navigators are doing, what kind of resources they're providing. It just helps us stay ahead of the curve. So those are kind of the things I like to do. And so it just helps us be a little bit more efficient. Digital navigation accessibility is important. We get a lot of navigation programs come and spend time with us. They want to know how we work. And so we set up a curriculum. We're in the process of developing a digital or online navigation curriculum with a focus on underserved populations. And so we have this curriculum team. Anita's leading that, along with one of the C-STAR research scientists in the Department of Surgery. And we have a medical education specialist, Christina Gonzalez. And we developed a CAB, a Community Advisory Board, which has worked out really well. And we have our core competencies from coordination of care, interpersonal skills and communication, patient-centered care, personal and professional development, and patient advocacy. And so these are all core competencies that we strongly believe in came out of this CAB that navigators need to have when dealing with patients. And then these are the curriculum topics. So I'm just going to end by just saying that from program to policy, it's really about scaling equity. We optimized the electronic health record to improve communication, provided digital navigation to support the Welter's patients' use of the MyChart and EMR, and leverage the digital tools. And really exploring models of collaboration between nurse navigators and social workers to address patient needs. And Also building on that R01 to advance breast cancer care for patients with disabilities. The way I see it now that I'm over at Rutgers, is that the future of breast cancer care over there is capitalizing on the momentum. There's a huge diverse patient population. It's a very large system, as you know, and there's a huge opportunity to make an impact there. We have locations in key areas of New Jersey, and we're expanding and with great leaders in the disease management groups with very strategic recruits and growth under Dr. Labudi and Richard Alexander's leadership. So I'm very excited now to be on the other side of the river to continue doing the work that I'm doing here. So in summary, health disparities are preventable. Equity requires intentional infrastructure. Access is necessary, but it's not sufficient. Just really keep that in mind. And that navigation is the evidence-based solution to address inequities in access to screening and oncological care. And surgeons can be leaders and advocate for equity as a core quality of care priority. So I'm just going to leave you with this quote from Maya Angelou. I love this quote, that do the best you can until you know better, and then when you know better, you can do better. Thank you so much.
Thank you so much, Dr. Joseph, Kathie. So I think we'll open it up for questions. Um, I will start with one question, and it's really great that you had engaged students in some of the work that you're doing. And I wanted to ask you, definitely they are engaged on the research and analysis part. How engaged were they in the area of, like developing the program, working in the community, working with the navigators, like kind of really learning the system of improvement from inside?
That's a great question. We often had students shadow our navigators. We had a lot of students that wanted to spend time with our navigators. Our navigators have to, they have a system that they have for how they approach the patients and so forth. But they often would spend time with the navigators to get to learn what the navigators do.
Mhm.
It was actually very well received. And oftentimes I would get asked to give lectures to the students, and I would bring the navigators with me so they would know and have the navigators also speak to them about the work that they do. So that was another way that we would engage them.
Mhm.
For the research part, um, that was a really great opportunity for our students to get an opportunity to learn the other side of just putting together the work. And we often would include, um, Anita, who's our manager, senior manager, on the papers that we published. The work on the disabilities and the screening, that was a JAMA surgery manuscript that got published by Madison. And she started that as a first year medical student. And she actually presented that at several meetings. So, yes, our goal is always to get our residents and students engaged in the work. So, yeah, it's been
That's
great.
fantastic. I'll open it up to everyone. You can unmute and ask your questions if you have any.
Dr. Joseph Stantrellecki from the school. Fabulous talk, and just really eye-opening in so many ways. And
Thank
you've
you.
made such a powerful case for the social and sort of environmental imprint on tumor biology. Doctor, I'm a biomedical researcher, and I just wonder um, where we stand in your view on better understanding, triple negative breast cancer and the higher incidence that appear to exist in the populations that we're talking about. And please, I certainly understand you need 4 hours to try to disentangle the genetics from all of these beautiful determinants that you've described. But I was just wondering if you could give just a short answer to address that from my perspective.
Correct. Yeah, that's a great question. And thank you. That's a great question. And we do know that Black women are 30% more likely to have triple negative breast cancers. And they are more aggressive. And reason why, for those on the call that may not know what those are the cancers. They're called triple negative because when we test tumors, they're negative for estrogen and progesterone and HER2. So we can only treat them with chemotherapy, but there's more therapies out there, and so it's still an issue. It's still something that we are more concerned about because Black women are more likely to be diagnosed. But it's interesting that when we're looking at the data on, for instance, in young women and Black women are more likely to be diagnosed at a younger age. The It's interesting as we're looking at the teasing out some of the data on the mortality rates and so forth. The problem is with the women who are estrogen receptor positive, and it could be because they may not be following through with their treatment, because remember, when you're estrogen receptor positive, you have to follow through and take your medication and so forth. So it's not so. I know and I'm not saying that triple negative is still an issue, but we have to make sure that people understand that just because you're estrogen receptor positive, you're not out of the woods, because you still have to follow through with your treatment. And so there is still a disparity with the estrogen receptor positive patients as well between Black and white women. And I think that's something that doesn't get acknowledged enough.
Much appreciated. That's
Sure.
very interesting. Didn't know that.
Yeah, exactly. Yeah, it is. And that could be part of the reason.
Thank you.
But we're getting there. Again, the whole thing is there's still, we have CDK inhibitors now
Mhm.
that are, but again, it's access. And so it's making sure that all populations have access to these new treatments that are on the horizon. We have the CDK inhibitors now that are wonderful, and I've seen them make a big difference. But we have to make sure that everyone has access to these new medications that are on the horizon.
Thank you.
Sure.
Thank you so much. Any other questions?
Hi, Dr. Joseph. My name is Jacqueline. I have a question. I'm one of the students at Hackensack Meridian. So I feel like so far as a medical student, I've learned a lot about at a micro level how to help patients navigate, healthcare systems, how to counsel them when they receive news. I wanted to get your advice, or if you have advice on how to get involved into more of these systemic programs like the one you implemented, or how to, as a physician, advocate for a hospital system implementing these programs.
So I would say that's a great question, Jacqueline, and thank you for asking that question. You Just asking that question, everyone can be an advocate and everyone can be a leader. Um, Wherever you are, if you're as a student, as a resident, you can always look for opportunities to advocate for your patients. Um, and depending on whatever you decide to do, I mean, honestly, the way this could be a whole nother talk, and I am happy to talk about my path and my journey. It's just, I just saw a need. I saw the gap, and that's how my work evolved. And so you can look for organizations or look for mentors who are doing this type of work. And there weren't that many when I was starting out, but I partnered with people outside of my field, and it grew from there. There are more people doing it now than when I started. Um, but but when you see something that you want to see addressed, I would say go for it. And see what you can do to fill that need. I mean, that's what leadership is all about. And if there isn't anyone doing it, then you start something. And that's kind of what we did.
Thank you so much.
Yeah.
Any other questions? If not, then thank you so much for this wonderful talk. You opened our eyes in many ways, and your work has been incredible and appreciated. And we hope to talk again and get a
I would be happy
conversation
to.
going.
Thank you for having me. I really appreciate it. Thank you.
Thank you. It was wonderful to see you. Have a good one, and thank you everyone for attending this. And we'll have this available in recording.
All
Thank
the
you,
best.
everyone.
Have a
Thank
good
you.
evening.
Have a
Bye-bye.
good